Good afternoon, everyone. My name is Dr. Ayanna Robinson. I am the Research and Evaluation Director at the Black Mamas Matter Alliance. I hope you are enjoying Black Maternal Health Week so far. Welcome to our webinar titled Healing Legacies, Using Data to Improve Black Maternal Health Outcomes. Our expert speakers will share their findings and discuss how data can be leveraged to shape policies, improve care, and advance health equity for Black mamas and birthing people. Held annually on April 11th through April 17th, Black Maternal Health Week is a week-long campaign founded and led by the Black Mamas Matter Alliance to build awareness, activism, and community building to amplify the voices, perspectives, and lived experiences of Black mamas and birthing people. The 2025 Black Maternal Health Week theme, Healing Legacies, Strengthening Black Maternal Health Through Collective Action and Advocacy, emphasizes the power of Black-led perinatal, maternal, and reproductive health organizations to drive systemic change and foster community healing. Next slide. Before we get started today, I would like to extend a special thank you to our Black Maternal Health Week 2025 sponsors, including our presenting walk sponsor, Pampers, and our Changemaker sponsors, California Healthcare Foundation and Merck for Mothers. Next slide. Black Mamas Matter Alliance is a network of Black-led and Black women-led organizations and multidisciplinary professionals whose work is deeply rooted in reproductive justice, birth justice, and the human rights framework to ensure that all Black mamas have the rights, respect, and resources to thrive before, during, and after pregnancy. BMMA is the premier Black maternal health professional organization focusing on building the skills, convening, and mobilizing the global Black perinatal, maternal, and reproductive health workforce to end maternal mortality. BMMA honors the work and historical contributions of Black women's leadership within their communities and values the need to amplify this work on a national scale. For this reason, BMMA does not have chapters. The Alliance is composed of existing organizations and individuals. Next slide. BMMA centers the technical training and development needs of the Black global maternal, perinatal, and reproductive health workforce through the following themes: changing policy, introducing and advancing policy grounded in the human rights framework that addresses Black maternal health inequity and improves Black maternal health outcomes, advancing care for Black mamas, exploring, introducing, and enhancing holistic and comprehensive approaches to Black mamas care, cultivating research, leveraging the talent and knowledge that exists in Black communities, and cultivating innovative research methods to inform the policy agenda to improve Black maternal health. And last but not least, shifting culture by redirecting and reframing the conversation on Black maternal health to amplify the voices of Black mamas. Next slide. BMMA uses the phrase Black mamas to intentionally include a range of people: cis women, trans folks, and gender non-conforming and expansive individuals with or without the capacity for pregnancy, who are of African descent across the diaspora, to those who care for and mother our families and our communities, whether they have given birth or not. We stand in solidarity with all Black mamas. Next slide. Our webinar today will explore how data and research can drive real change in Black maternal health outcomes. Next slide. It is my privilege to now introduce our presenters for the webinar today. Our first presenter is Dr. Sayida Peprah Wilson. Dr. Sayida Peprah Wilson is both a psychologist and doula with over 15 years of experience in both fields. She specializes in multicultural psychology, trauma, suicide prevention, and perinatal mental health, and has practiced in community-based, in-home, psychiatric, hospital, and prison settings. An advocate for human rights in childbirth, She is a member of the Black Women Birthing Justice Collective and a movement partner with the Black Mamas Matter Alliance, promoting research, education, and community-based services to positively transform the birthing experiences of Black families. Dr. Sayida is the founder and executive director of the nonprofit organization Diversity Uplifts, Incorporated, whose mission is to improve the well-being of women, birthing people, children, and families, and increase cultural competence and humility among providers who serve them. She is also currently serving as a member of the DHCS Doula Medi-Cal Stakeholder and Implementation Work Group Community Communications Advisory Team. Thank you, Dr. Peprah Wilson, for joining. Next up, we have Dr. Karen Sheffield-Abdullah. Dr. Karen Sheffield-Abdullah is a certified nurse midwife, a mindfulness instructor, an assistant professor at the University of North Carolina at Chapel Hill School of Nursing, whose professional and personal interests center around the experience of stress and anxiety in Black women and birthing people. Her research broadly targets the development of strategies to reduce the long-term health effects of psychological trauma, anxiety, and depression on Black women's health and their pregnancy outcomes. Her interests include the biopsychosocial benefits of self-compassion, mindfulness, and other mind-body therapies as adjuncts to conventional treatment modalities. Her research goal includes facilitating the development of culturally relevant interventions to reduce disparities in stress-related adverse outcomes and provide a platform to guide successful models of women's healthcare provision that incorporate stress management and improve wellness across the lifespan. And last but not least, Kimberly Seals-Allers is an award-winning journalist, five-time author, international speaker, strategist, and advocate for maternal and infant health. A former senior editor at Essence and writer at Fortune magazine, Kimberly is a leading voice on the racial and sociocultural complexities of birth, breastfeeding, and motherhood. She's the founder of Irth, a new Yelp-like app for Black and Brown parents to address bias and racism in maternity and infant care. Kimberly also created Birthright, a podcast about joy and healing in Black birth that centers on positive Black birth stories as a tool in the fight for birth justice and reverses the narrative of negative statistics common in the mainstream media covers of Black maternal health. Learn more at KimberlySealsAllers.com and follow her at IamKSealsAllers on Facebook, Twitter, and Instagram. Of note, if you have any questions for our presenters throughout the webinar, please feel free to drop them in the Q&A box or in the chat. Time permitting, we will have audience Q&A after the last presentation. And now I will turn it over to our first presenter, Dr. Sayida Peprah Wilson, to discuss ways to make data more accessible to community members.
Good morning, everyone, or good afternoon if you're in the East Coast. You can proceed to the next slide. So you heard a bit about my bio. One of the things that I want to say that grounds me in this work in research and in practical support to Black mamas and families is that as a psychologist, I worked in a lot of different spaces where people are facing the multiple levels of stressors. In addition to their pregnancies, they're also dealing with mental health or trauma. I've had a lot of background in suicide prevention, worked in psychiatric hospitals, in the prison system and jail systems, and community-based and domestic violence shelters. And being able to have that perspective of the experience of life and understanding the impact that pregnancy can have on a person's life, and thinking about all those multidisciplinary factors always informs the way that I think about research, so that we're not missing anyone who's vulnerable in the population and just thinking about sort of ideal situations when people are pregnant and postpartum. As I mentioned, I'm the founder of Diversity Uplifts. I'm also a consultant and trainer with Dr. Sayida Uplifts, LLC. And I sit on a number of, probably way too many, advisory boards. California's Pregnancy Associated Mortality Review, a number of perinatal equity initiatives in California, and some national Medicaid and doula and maternal health benefit sort of analysis and convenings. Next slide. I'm also a mother of two, and this is probably the most important aspect, I think, of being able to support around research, is that I've had my own lived experiences as a mother, giving birth to two girls, one in the hospital, one at home, both of them with midwives, but one in a home birth setting and one in hospital setting, have had concurrent care with OBs, have really explored in my own experience, even in coming into how I would have my own children, exploring all the options that I had and understanding the differences, but also the limitations. And I was able to have a home birth, but not because I had the money to pay for it. I was able to have midwives, and not because I was in an affluent situation where I was able to provide that. I had to really explore a lot of strategies. As many of you would know, midwives are covered in some places, but not in all places. And I was able to have hospital midwives support my birth in the hospital. And I didn't have insurance when I started my pregnancy. And at the time, you couldn't even get insurance if you had an existing condition, which at that time was pregnancy. And so I got on our state Medi-Cal in California, which is Medicaid for everyone else. And came into a system where I was just at the whim of whatever was available to me. And so in my own experiences, I try to lift that up in the research and think about areas where people are not typically, researchers are maybe not coming from the population where they're also investigating. And so I'm able to bring that to the table. Next slide. Uplifting Black voices in research. So I am also a doula, if I didn't say that, and have been a doula for many years. Once I had my children and somebody had gifted me a doula, I realized what a doula was, and that I had been doulaing all my life, had been supporting births and supporting folks and accessing reproductive care. But I took the journey on myself and became a doula. And through that experience, being a doula, being a psychologist, supporting around information and education on both sides of the mental health and the maternal health space, I came to connect with Black Women Birthing Justice, and was able to join in as they were wrapping up the Battling Over Birth report. And so I want you to know about this report. This was 100 Black women sharing their stories around maternal health in California. I was able to bring on a Southern California cohort, predominantly BWBJs in Oakland and in the Bay Area, Northern California. This research is really significant because it tells a story from people. First of all, the researchers were Black women. Those that were participating in the research were fully included in understanding how it was going to be used, and were, offered the book themselves so they could see where their stories went in research, which doesn't always happen. Typically, people are investigating research and then asking people for all this information and not giving anything back to them. We also did it in a healing setting, so that we were together in a room with food and snacks, and it felt more like a healing circle than a focus group. And the evidence, the information, the data that was collected from these individuals was able to set a stage, particularly for California, but I think for folks that really appreciated the work everywhere, to understand from the experience of Black women what they would recommend. So we got to hear Black women's recommendations to policy, to the healthcare system, to providers, to their families, and to their own selves. Like, what could we do for ourselves as pregnant and postpartum people? Then in the Birthing Justice book, myself and Mama Linda, who's on the left there in the picture, we're able to offer with so many other folks chapters about the experiences of both Black providers and people who are giving birth in our system, and provide wisdoms to folks so that people can think about ways to center Black women's voices. So the QR codes are there. If you have not been familiar, you're welcome to see about those articles and reports. Next slide. I've been blessed to be a part of BMMA's multidisciplinary research working group. And in this particular edition of the Black Maternal Health Research Reimagined, this was really an opportunity to help people who are doing research think about ways to do it that's Black-centered, that's informed by Black women-led researchers. So thinking about holistic care practices, reimagining how you can do research, including the community themselves at the start, through, and in the evaluation phase as well. Next slide. Centering Black mamas in California, I was able to be a part of this review. There had not been a review. You could click one more time. There had not been a review of specifically Black maternal health outcomes and infant outcomes for over a decade in California that really focused directly on our experiences. So there was a convening with the public health department and a set of Black women who are in different aspects of the fields, so that we could take a look at that data ourselves, not have just the state evaluate the data, and determine what we saw were significant things to lift up. What do we know is needed in the community? And so one of the things that was identified in this research analysis was that neighborhood conditions were influenced by discriminatory policy, which many of us know. Next slide, and you can click twice. Chronic stress created by racism and racist policies was active and evident in the data, and a lack of access to high quality and respectful healthcare. Next slide. Another thing that I love to do is use data not just for researchers and not just for policy, which is very important. We need policies to be shifted. We need health systems to change, but we also need local providers to understand what is in the landscape. And so Diversity Uplifts and a number of the organizations that I support and am a part of, Black Women Birth and Justice, Sankofa Birth Workers Collective, Frontline Doulas, we use our data in our community-based birth worker programs to train the doulas that we're working with and future doulas. So we actually take the data that we have, that we've collected from what we know is actually happening with families, and feed that back in our mentorship calls and in our mentorship meetings with our doulas and birth workers. And that work then extends, because many of us do trainings with OB providers and midwives and nurses and health systems. And we're able to use live, very active data that's happening that is basically just the voices of people who are having experiences in our system. And so we lift up the common themes that we see, challenges that people are having, barriers that folks are having. And one area where I've been really blessed to be able to be at an intersection is supporting around the co-design of the Medi-Cal doula benefit in California. There's always a lot of questions as people are trying to build policy around certain types of birth workers. What is the scope, and what are the elements that we need to think about relating to barriers? And because we've had so many community-based doula programs in California for years before the Medi-Cal benefit was being considered, we actually were able to come to the table, to the state, and make strong requests / demands for certain aspects that we knew were going to be important, having flexibility in postpartum support, because people need care more than just 6 weeks after birth. Particularly if they're in the intersection of poverty or housing issues or just life. And just why don't we support people who are giving birth and bringing forth life longer than a couple of weeks after they have gone through a very intense experience and are now nurturing another human. And so just really being able to lift up the actual stories has been powerful. So it's a recommendation that all of us really have, is to lift up the real stories for people. It has made a huge difference in convincing people to allow for policy to be more expansive than people had initially imagined. Next slide. I want to say something about the emotional impacts of racial disparity data. As a psychologist, as someone who not only does work in the maternal health field and research, but I'm also a supporter. As a psychologist, I'm a doula, a psychologist / doula for the doulas, for the birth workers, and for a lot of people in the systems, for the data researchers. It's heavy work looking at the challenges that Black women and other communities have had in this system that is not set up to really provide what people need when they're giving birth and in the postpartum period. And so it can be really emotional to look at the rate of death among Black women, to look at the rate of morbidity among Black families. You can turn to the next slide too. So one of the things that I often teach about and think about is the vicarious trauma, secondary trauma that folks can experience. So this is trauma that people can experience after hearing traumatic stories, witnessing the pain and fear and terror of trauma survivors. Next slide. Vicarious trauma looks like, for many people, a state of tension, preoccupation from hearing the stories of others. A lot of times I'll hear, families come into our doula programs saying that the reason why they want a doula is because they're afraid that they're going to die during childbirth, right? And so we know that it's been very important for us to lift up the concerns that are happening. There is a crisis happening in the community, but we also don't want people to be afraid of something that we've been doing since the beginning of time. And even though the statistics may be higher for Black women, we are not when you have a statistic, so go to the next slide. We are not meant to be expected to die just because we're giving birth. So I have some thoughts about the ways that we can communicate data to be less scary, to be more supportive of the shifts that we need to make, rather than just sort of terrorizing ourselves and other people. So one of them is, I think you can click 2 more times. One of them is consider adding relevant uplifting data to the reports on disparities. And the other one is to consider replacing and or reframing like horrific statistics with uplifting or solution-focused statistics. So I want to give some examples. These are real statistics that exist. In 2021, Black women were in prison 1 to 6 times the rate of white women, and Black men were in prison 5.5 times the rate of white men. So that's one statistic that you could put at the top of an article. Another one is that from 2000 to 2021, the imprisonment rate fell 70% for Black women and 48% for Black men. And this was the highest decrease among all races. So we're still talking about the rate of imprisonment. These are still facts. But what do we decide to perpetuate in the community, and to what purpose? So for me, I think a researcher, providers, health systems, they need to understand horrific disparities so that they can be moved to make shifts. But when I'm communicating to community, I want the community to know this is important for you to know so that you can make sure you have a doctor who listens to you. These things are important for you to know because it's important for you to see as much as possible to establish your health, prior to pregnancy and during pregnancy, right? To motivate positive behavior rather than just sort of grip people in fear. Another statistic is Black women die from pregnancy-related causes 2 to 6 times the rate of white women. Another way to say that could be that Black women are 2 to 6 times more likely to die, right? But when you say that they're more likely to die, it makes me feel when I'm listening, like I'm more likely to die. It's the same thing to say that the rate is higher, which is actually just the statistical reality, is that the rate is higher when you're looking at a scale of Black women. It doesn't mean that I am personally more likely to die. I don't have to take that in for myself. And then the other thing is that 80 to 75 to 95%, even in some 98% of maternal mortality deaths have been deemed preventable. So if I tell somebody that you're more likely to die, and I don't tell you that it's also preventable, the majority of these deaths, then you leave people thinking that they could die rather than I could prevent something. So just something really significant to consider. Next slide. Something else that I also think is important in this climate and in general, is that because we have focused on Black women being the focus of the deaths, the largest amount of deaths, which is absolutely true, and we do need to center Black women as a result of this, I think people don't realize that white women in America are also significantly more likely to die than their white counterparts in other countries where they are represented as a racial group. And I think I would want to know that, right? And so I think that if, we consider that I think that I would love to imagine that everybody's compassionate enough to care about all the people, the most vulnerable people. But somehow, if people are not compassionate enough, they might think about themselves, and people should not be confused that even though Black women are dying at higher rates, everybody's dying in America at higher rates than they should be in comparison to what's happening in the global space in maternal health. Next slide. Thank you so much for giving me time, and I look forward to the discussions after.
Thank you, Dr. Peprah Wilson, for sharing all of the insightful work you are doing, and we certainly appreciate the tips and reporting data and communicating to the community and the importance of shifting data from solely inducing fear, which is important, to really being able to make informed decisions about maternity care and childbirth and advocate for oneself. I saw someone in the audience say, yes, like we need hope. So absolutely. So we thank you for sharing those insightful tips and for all of the information that you shared. And now we are going to hear from our next presenter, Dr. Karen Sheffield-Abdullah. So turn it over to Dr. Karen.
Thank you, Ayanna. Just making sure you all can hear me. How's my sound? You can hear me?
Yes.
Okay, great. So thank you for the invitation, and really honored to be able to come and speak today about how we heal our legacies and how we can use data to improve Black maternal health outcomes. I'm Dr. Karen Sheffield-Abdullah, and so much of what Dr. Sayida just talked about really resonated, and I really appreciate her perspective and contribution to the community. So with next slide, please. So this slide, it looks like the settings are a little bit off, but just to let you know that there are certain funding sources, and what I'm going to talk to you about, there are certain funding sources that allowed the research that I'm going to share with you to happen. And so just wanting to acknowledge that. Next slide. So my bio was already read, so I'm not going to say much more than that, but just emphasizing that there are three things that I'm really passionate about. And really it's about women's health across the lifespan, that of birthing people and women, and thinking about psych mental health, right? Psychological distress. I'm actually really interested in anxiety. I think we study depression quite a bit. I don't think we study anxiety nearly enough. And I think the ways in which the Black community experiences stress, distress, anxiety, and depression is very different than the ways in which the global minority talk about it. And much of the screeners that we utilize when wanting to assess psychological distress don't really resonate with us. So I think that the prevalence of a lot of our mental health outcomes are much higher than what we actually report. And then I'm also very interested in integrative health approaches like mindfulness, and mindful approaches really guides the work that I do. In addition to being an assistant professor, a mindfulness instructor, and also a nurse midwife of 20 years, I really want to emphasize and highlight that I'm a mother of 4. And I have a 27-year-old, a 24-year-old, a 22-year-old, and I'm a bonus mom to a 14-year-old. The 27-year-old was delivered by a physician. The 24-year-old was delivered by a midwife. That's when everything opened up for me. And I decided I want to go back and become a doula. And then I was a doula, and then decided to become a nurse midwife because I wanted to move the midwife or the birthing attendant out of the way and be the one to have my hands on catching babies. And then the third was an unplanned home birth. So really just wanting to say those third babies can come out fast. And so I've had kind of the experience of birth across from having a physician to having a nurse midwife to having an unplanned home birth. So moving on to the next slide, please. So I always like to start with this quote by Dr. David Satcher, former US Surgeon General. You cannot have health without mental health, right? So really leading with the fact that they are inextricably connected. And the ways in which our mental health is impacted absolutely impacts our physical health. So if we think about what's going on in the world today, we certainly know that the amount of vicarious trauma, traumatic stress, toxic stress that our bodies were never set up to be dealing and coping with on a chronic basis in the way that we are experiencing it, it absolutely leads to the outcomes or are associated with the outcomes that we're experiencing. So next slide, please. Talking specifically about maternal mental health, which is an area that I'm really, really passionate about. Next slide. What we know are that maternal mental health conditions are the most common complication of pregnancy and birth, affecting over 800,000 families in the United States. Next slide. And in fact, we also know that 75% of women that are impacted by maternal mental health conditions remain untreated, which increases the risk of negative impacts on mothers, babies, and families. And so let's take a moment just to think about, why does it remain untreated? Is it an access issue? Is it an issue of I'm not going to tell people my business? Is it an issue of stigma? Why are we remaining untreated? Is it because we don't talk about our stress and our psychological distress in the same way, so it gets missed? Is it because healthcare providers don't have the time? Or we fill out the screener, they look just to see if we circled certain items, and if we didn't, it never gets discussed. So really wanting to think about why is it that we remain untreated? Next slide, please. In full disclosure, I should mention that, yes, I am an assistant professor at UNC Chapel Hill School of Nursing, but the views that I'm going to be sharing with you today are my views and my views alone and related to my research. And one of the things that happened when I was a pre-doctoral candidate was that I said, I really want to talk about anxiety for Black women. And I was met with, you know what, Karen, anxiety is not fundable. Nobody's going to fund anxiety. But when we associate the cost with the baby, right, then that's what gets fundable when we can talk about the bottom line. So I feel like I have to include these types of slides that say untreated maternal mental health conditions is a $14 billion cost. And the cost of not treating maternal mental health conditions is about a $32,000 per mother-infant dyad. Go to the next slide, please. What are the numbers for Black perinatal people? I'm not going to ask that we click on this link, but just know that the Maternal Mental Health Leadership Alliance has a really nice fact sheet that we can access that talks more about the maternal mental health outcomes for various populations. Next slide, please. So back in 2020, the CDC reported that suicide and overdose are the leading causes of death for women in the first year following pregnancy. And when this data came out, I was contacted by the media to come and talk about it. And I talked to my CDC colleagues and I said, what would you like me to say about this? And one of the biggest things that I want to make sure doesn't get overlooked, that yes, suicide and overdose were leading causes of death for women in the first year of pregnancy overall. But for Black women, cardiomyopathy, postpartum hemorrhage were still the leading causes. So just wanting to frame that for us. Go ahead to the next slide. Just talking a little bit about perinatal substance use disorder. I have served on the North Carolina Maternal Mortality Review Committee as the nurse abstractor, looking at all of the opioid overdose related deaths, and just wanted to bring in a few statistics here. Approximately 7% of individuals report prescription opioid use during pregnancy. 14% of pregnant people report drinking alcohol. There's limited data on cocaine use and methamphetamine use during pregnancy, as you might imagine. It's hard to collect that type of data. And it's hard to know the full extent of perinatal substance use due to underreporting because people are worried about the consequences. If I tell you, or if I am vulnerable enough to share with you about my substance use, is CPS going to show up when I deliver my baby and you're going to take my baby from me, right? Next slide, please. So wanting to also just emphasize that approximately 26% of individuals will experience perinatal depression and approximately 21% will experience perinatal anxiety. And as you know, I already said, I think this is underreported. Next slide, please. So in 2020, according to the World Health Organization, the number of people who are living with anxiety and depressive disorders rose significantly because of COVID-19 pandemic. This is what the World Health Organization says. What I would say is that we need to be looking at what was happening concurrently during this time, right? And how might we think about the fact that there were concurrent pandemics happening with racial injustice and unrest, right? So thinking about the George Floyd, Ahmaud Arbery, Breonna Taylor, so on and so forth. So I think that that is a major contributor that may be being overlooked as we think about these initial estimates of increasing in anxiety and depressive disorders in just 1 year. Next slide, please. So in doing my formative work, what I really wanted to do was understand what are the individual and perceived factors that may contribute to the persistent racial and ethnic disparities that exist for Black women's pregnancy outcomes. So really wanting to look at the stress and psychological distress that Black women experience and how it impacts pregnancy outcomes. Next slide, please. So thinking about the statistics that Dr. Sayida was saying, let's not just think about statistics, but we also need to be able to tell the story as well. But in terms of statistics, Black women and their infants experience twice the rate of preterm birth and low birth weight compared to their white counterparts. And this disproportionate rate of adverse pregnancy outcomes persists even when we control for maternal education, socioeconomic status, and prenatal care. In fact, we know that a PhD prepared Black woman will have worse birth outcomes than a 8th grade educated white woman. And why is that? Next slide, please. So I postulate that maternal stress may explain these disparities, right? And we also know that Black women experience greater levels of stress compared to white women, right? And it's a shame that we have to put a study to that, but indeed, yes, there are studies that show that that is indeed the case. So next slide, please. Exploring the role of the unique factors of stress and psychological distress and their potential impact on pregnancy outcomes are really significant pathways to consider. I do that utilizing Superwoman schema and network stress. Next slide, please. So Superwoman schema, next slide, is a conceptual framework that was developed by Dr. Cheryl Woods-Giscombe, who is a senior associate dean at UNC Chapel Hill School of Nursing. She was my dissertation chair, colleague, mentor, and friend. And basically her conceptual framework says that there are certain social, historical, and cultural events that have happened in this country at the intersections of race and gender that have caused some Black women, not all, but many, to take on 5 hallmark characteristics. There are 5 hallmark characteristics. Next slide, please. An obligation to maintain an image of strength, an obligation to suppress emotions, resistance to being vulnerable or dependent, determination to succeed despite limited resources, and helping others even at the detriment of our own health. Next slide, please. So network stress is simply the stress that exists that we experience from family, friends, and loved ones. So basically for Black women, in a study done by Dr. Woods-Giscombe and Sinead Wiley and Giselle Corby-Smith, they found that Black women were exposed to a greater number of network stress related events as compared to self-stress. So what does that mean? It means that if my best friend, my girlfriend, is going through a divorce, I'm going through that divorce with her. I am stressing out. I'm appraising the stress of my family, friends, and loved ones higher than I appraise my own stress. So it's really important for us to be thinking about the stress of the network when we're thinking about solutions. Moving on to the next slide. So complementary and integrative health approaches, why am I interested in that? I'm interested in that because not everyone wants to take medications to manage their stress and psychological distress, especially during pregnancy. So coming up with solutions that are non-medication based are really important as we think about what type of programs and interventions we can put into place for this population. And so what I want to draw your attention to in this slide from the National Center of Complementary and Integrative Health is the mind-body practices. And indeed, we know that with mindfulness, which is a mind-body practice, it is associated with decreased pain, decreased stress, decreased anxiety, decreased depression, improved quality of life and well-being. Next slide, please. So with complementary and integrative approaches, you might imagine that there are very few studies that have been examined specifically in Black women. And to my knowledge, only one has been done with Black perinatal women by Zhang et al. In 2015. Next slide, please. So what is mindfulness? Next slide. I am trained in mindfulness-based stress reduction, which was developed by Dr. John Kabat-Zinn. And it's basically about paying attention in a particular way, on purpose, in this present moment, to what is actually happening and doing that in a non-judgmental way. And so with mindfulness, what I found when I started mindfulness 15 years ago after my mother's breast cancer diagnosis, and I realized that my stress was at the stratosphere and I wanted an alternate way to think about how to manage my stress, I went to the classes and I looked around and I was like, there's nobody that really looks like me. Right. And when they were reading a poem, I'm like, what you reading? I don't even know what are we talking about? Right. So I really felt a call to develop a culturally relevant, trauma-sensitive, person-centered, mindfulness-based intervention or program to address stress and psychological distress for Black perinatal people. Next slide, please. So I did a study that involved 9 different surveys, and I did in-depth interviews. And I did that because I wanted to understand at its core, what is the lived experience? How do Black perinatal people talk about their stress? How do they define stress? How do they cope with stress? Is there anything uniquely stressful about being pregnant? Is there anything uniquely stressful about being Black and pregnant? And they told me. And this is how the data is informing the program that I'm developing and hopefully getting funded, right? So next slide. We don't have time because I've been given the 1 minute warning, but next slide, please. Demographically diverse sample, but what I want you to know, you can go to the next one really quick, just drawing your attention to the way in which, when I asked them, which of the following medical conditions do you have? The top 2 reported were anxiety and depression. So you know what I said to my dissertation committee. I told y'all anxiety was a thing with Black perinatal people. We are not picking up on it. And when we look at the way they scored on the anxiety scales, next slide, please, you can see that the mean score for the anxiety scale indicated moderate anxiety. The perceived stress indicated moderate stress. And for the depression, a score of 16 or greater can indicate clinically significant depression. So you can see that I was operating with or working with a very stressed, anxious, and depressed sample of individuals. Next slide, please. Correlational analyses, very quickly, the higher they scored on Superwoman schema, guess what? It was positively scored. They were more anxious, they were more depressed, they were more stressed. And similarly, the higher they scored on Superwoman schema, less mindfulness, less self-compassion, less mindful self-care. Next slide. I don't have time to get into the linear regression analyses, but I'm happy to talk to anybody about this work. Next slide. We can kind of go on to the qualitative finding. When I asked them about stress, they said they felt anxious, overwhelmed, and overloaded, period, right? And when I asked them about what the unique stressors were about being Black and pregnant, they said the judgments and assumptions that are made by others, feeling isolated, and the stress they experience from their network. Next slide. We can go through, we can just go ahead through. I just want to get maybe to the almost last slide. So conversations with healthcare providers, really quick, I asked them, so are you having conversations with your healthcare provider about your stress? What do you think they said, y'all? No, right? And why is that? Healthcare providers don't really have the time to have the conversation. So one of the things that I want to do is to be able to impart to my healthcare professionals, my fellow midwives, physicians, that we need to slow down, have the conversations, listen to Black women when they tell us stuff is going on. Next slide, please. And then I want to just talk about the way in which I've incorporated what Black women have said to me that is stressful. And when I asked them if mindfulness would be acceptable, 100% said yes, mindfulness would be acceptable. I was like, well, all right, because I don't want to assume that mindfulness will work for this community. It needs to be community engaged. They need to tell me. And they said, yes, mindfulness absolutely would be acceptable. And I said, what would you want to see in it? They told me, so I have created it. So I do have a business, Dr. Karen LLC, and I've created luxury mindfulness experiences for Black women, right? For us to be able to come to a space where we can turn down, dial down the noise, prioritize ourselves, and be seen, heard, and valued. Happy to take questions at the end. Thank you for your time and letting me go over. Next slide, please. I think that's just my contact information, and I can drop that in the chat. Thank you so much.
Thank you. Thank you so much, Dr. Sheffield-Abdullah. We appreciate learning about the work you're doing on the important topic of maternal mental health and really seeing examples of how you are going to the community, listening to the community, using their thoughts, their words to inform the programmatic actions, like as it should be. And thank you for the ways in which you explore anxiety among Black women and birthing people, which, as we know and as you have shown, is often overlooked. So thank you so much. And with that, we will turn it over to our final presenter, Kimberly Steels-Allers.
Good afternoon, everyone. May I have the request to share? May I have the ability to share? I apologize that I am not fully home. Delta did not want me to be great today. So if you hear any background noise, hopefully I will be able to present over it. Let's see if I can just share my slides. There we go. Thank you so much. Such an honor to be here and to be able to talk about, be with some of my favorite academics, but to also talk about a different way of thinking about data collection and really the use of technology. For those who don't know, our signature platform at Narrative Nation, can everyone hear me okay? Sure.
Yes.
Heard. Okay, great. Thank you so much. Is the Irth app, which is really a tool for us to gather information particularly around something that we don't need to talk about, which is racism and bias as a root cause of the issue that we all care about. So, but when we think about solutions, we want to acknowledge that many times these anti-bias trainings don't have any accountability. And that many times when we're only looking at clinical outcomes, we forget about the experience of the care, right? And then we also need to recognize that maternal mortality and morbidity is the floor, not the ceiling, right? Just because someone didn't die or nearly die doesn't mean they had the experience that they deserve. So how do we actually capture data to make sure that people are getting the experience that they deserve, that they want, beyond just not dying, right? That seems to be a very low bar. And then our process is transparent for those who don't know, because we understand that the reason why Black and brown folks are not responding to age caps, they're not responding to Press Gainies, is because of this lack of trust. And so we use transparency as the fastest way to repair trust and as a new way of thinking about who owns data and who has access to it. So that's really important. For those who don't know, Irth is like birth, but we dropped the B for bias. It's the first of its kind nonprofit rating and review platform designed just for Black and brown women and birthing people to find and leave reviews of OBGYNs, birthing hospitals, and pediatricians. But on the back end, Irth is a data aggregator. It actually turns our anonymized reviews into robust patient-reported insights. It allows us to work with hospitals, payers, providers, really developing what is the first nationwide database of experiences of BIPOC people in maternal and infant care. And so we're excited about the way that we do this work. One of the things that's important when we think about using consumer-facing technology is that we don't have the data lags that many other data sources may have. And then I think particularly in this political climate, it's important to understand that we need to have our own data sources. We need to have our own mechanisms for accountability and transparency. And we need to have our own tools for keeping each other safe. And so this is really what Irth is about, but also having this ability to look at trends, patterns, frequencies, et cetera, et cetera. So Irth is a structured review process. It's not a free-form commenting space. It is a review designed to generate data. We accept reviews not just from the mama or birthing person, but we also accept reviews from fathers, from partners, from doulas as well as hospital-based midwives, so that we can get that whole perspective on what is going on. We have 4 review types: prenatal, birthing, which asks about the doctors, nurses, and lactation consultants. We have a postpartum review for the birthing person, as well as pediatric reviews for baby up to that first birthday. So we cover that whole perinatal spectrum. And then we have the app in English and Spanish, Haitian Creole on the website, and we are actually developing our Somali language because of our work in Minneapolis. One of the things I think Irth does well, we really, as you know, we can't change what we're not willing to see, right? And when we're talking about certain things, it may be abstract. What does bias mean? And what does disrespect mean? What is disrespectful to me may not be disrespectful to you. So how do we really get detailed information? So we ask lots of questions about both positive and negative practice behaviors to really understand what exactly is it that's making people feel harmed? Is it that their pain levels were dismissed? Was it that it was their physical privacy was violated? Was it rude comments? What are we talking about? So that we're not having abstract conversations. And the work acknowledges, so much to Dr. Karen's point, that there is a whole spectrum of harm that is going on in our community that is impacting postpartum mental health, that is impacting stress levels. And if we are only looking at mortality and morbidity, we're missing so much, right? So we really want to understand the whole spectrum of harm so that we can actually address that. So right now in our national database, Irth has over 35,000 users, and we have reviews from 46 states. The #1 negative experience being reported in our nationwide database is my request for help were ignored or refused. #2 is my pain levels were dismissed. 3, I was scolded, yelled at, or threatened. Deeply concerning the number of Black families who are being threatened for making decisions about their babies and their bodies that, quite frankly, they're allowed to make. And then also physical privacy violated and assumptions based on racial stereotypes. And I want to draw your attention to #1 and #2, because it's important to note that likely in pretty much every story that you've read of a Black maternal death, somebody was asking for help and they were ignored, and somebody was in pain and it was dismissed. And so we really use this up-to-date information to be an early warning detection system. How can we identify the patterns in our data, the behaviors that we know disproportionately lead to harm, identify it early, alert those facilities and those providers so that we can actually prevent deaths. This is really my goal and the hope and the work that we do to really identify these patterns before they become an adverse outcome so that we can be an early warning detection, so that we can actually prevent deaths and identify these harmful behaviors. How do we drive systems change? Right now, we work in 4 key ways. One is through our direct hospital partnerships. These are typically 18-month to 2-year processes that we go through with a hospital partner, taking them through a in-depth quality improvement process, a quality improvement process that is rooted in Black and Brown voices, something that really doesn't exist. We also work with city and state collaboratives, providing data to inform what they're doing, whether they're a perinatal quality collaborative on a statewide level or a state health department. We're also developing a pilot with payers because we know that if we can get Irth app reviews embedded into a provider incentive in our commercialized health system, that's a game changer. And so we're excited to be in conversation with several payers around how do we pilot a way to make sure that Irth app reviews are included in how providers are being assessed for a incentive or withhold. And then our publishing strategy, right? We know that right now hospitals are not being incentivized to a race for the top, and that many of them simply feel that if they don't kill us, that they've done a good job. And so we will be publishing our list. New York City is the first city where we will reach our data threshold. So this year we will begin to publish best places to birth for Black people based on Irth app reviews to really drive change. We want hospitals to want to be on the top of our list, and we want to engage those who don't make it. Right now, we're working with 8 hospitals across 6 states. Really excited. These are our hospital partners that we're going through that 2-year process with, including our large project in California, across the state. And that process starts with community review collection. And I want to talk a little bit about how we collect data, because I think that's so important around how we're really disrupting kind of commonly held practices around data collection and really trying to innovate and try something new. But the first part of this process that we go through is community review collection. We activate our Irth ambassadors. After we reach that goal of review collection, we will analyze those findings. We create an improvement plan. We actually bring in implementation scientists who work with us to analyze that data. What is it that the community is saying that's going well? What's not? What are the things to build upon? What are the things that need improvement right away? Then we try to come up with some short-term, medium-term, and long-term goals for the hospital to execute. Soon after that, they'll go into an evaluation period. This means that we will give them a certain amount of time to achieve something that we consider to be a low-hanging fruit that can be addressed rather immediately. When that time has passed, we will again activate all the things that we do around community engagement and generate a fresh batch of reviews. And usually our hospital partners want that next batch of reviews to be better than the first batch that we collected. So they're incentivized to do the thing that they said they were going to do in the time that they said they're going to do it. And then again, through our transparent process, we would report and share with the community through media these secondary findings. And we do that at various points throughout so that hospitals are being held accountable to doing the thing that they're supposed to do. These are some of our implementation scientists that we bring into the process, really helping us to create this new way of thinking about how do we take community learnings and turn it into strategic, actionable strategies for hospital partners. Right now, we're also working with city and state collaboratives, public health departments, also 3 state PQCs where we are doing multi-city review collection. That data is being shared up with that state PQC to support their statewide initiative, whatever their goals are. And that data is also being used to identify individual hospitals that need to come into our direct Birth Without Bias hospital improvement program. So it's a 2-pronged strategy. And then we had a great partnership with the March of Dimes, where Irth was actually being used as an evaluation mechanism. We went in first before they executed what they were doing. And then we went in afterwards to see whether the community actually felt the impact of their activities, right? And so whether we're working with hospitals, whether we're working with city and state collaboratives, whether we're being used as an evaluation mechanism, a community-centered evaluation mechanism for an existing project, we're excited and grateful for all the use cases for Irth. Our vision is around Irth being our good housekeeping seal of approval. We want our community to look for Irth-approved providers and Irth-approved hospitals, and that we can drive consumer demand for hospitals and providers who want to do better. And we do this by identifying who's doing well. We want to identify leaders and laggards, celebrate those who are doing well, identify those who are lagging, and give them support to improve. And the way that we do this, I think, is really helping redefine what data collection can look like in Black and Brown communities. So one of the things I'm really proud of and how we approach data collection is one, through our primary pillar within the Irth Ambassador program. We know that trust is an issue. We also know that at the same time, birth workers are not being supported or paid what they deserve, right? I was saying on social media that so many people are training doulas, but not enough are sustaining them. So we created an Irth Ambassador program that's all about us taking care of those who are taking care of Black birthing people. We go into a city, we actually employ birth workers, we give them a monthly stipend to come in and support our work. We also give them access to a mental health therapist because birth workers are dealing with a lot in their own work. We create a series for their professional and personal development. We have brands that send them nice things because we think they deserve that. And we create opportunities for networking, mentorship, and community. And in return, our Irth Ambassadors are the ones who are at every community baby shower. They are working with the churches. They are there helping us with social media promotion. They are our eyes and ears on the ground, and they support us in this way. And then another thing that we're doing around data collection is making sure that our users know that their story is valued. Right now in our new Crown Rewards program, our users can actually cash out to receive money when they leave reviews. And we're excited about this because we're also expanding this to have partners. We want our users to be able to get the things that they need and love, and that their story has value. And now we get to live that out by giving them access to goods and services, but also allowing them to get paid right within our platform when they leave reviews. And so we're excited about this idea that we're not perpetuating an extractive process, but everyone who leaves a review in Irth can get something in return. I know we're at time. I'm just going to share a little bit about the data that we do collect. Again, really looking at our national database, understanding the percentage of folks who are saying that their pain levels are dismissed. What are they experiencing around condescending tones, rude comments? What percentage of folks are saying that their requests for help are being ignored or refused? And we can also look at this on a, I think I skipped that one, on a insurance type, gender, sexual orientation, race. These are all self-identified within the platform. We also have a likely to recommend rating that we take very seriously. It really shows whether or not someone would recommend this doctor or hospital to a friend or a loved one. And that's also a piece of data that we look at in addition to our reported behaviors. Breastfeeding, really important. We ask about lactation support within the app. We know that this is ground zero, something I'm very passionate about. And so we also are looking at the quality of breastfeeding support and what people are reporting there as well. I see my co-presenters coming back on. So I will end with just our general mantra about how we approach data and divining solutions, which is whatever the question, the answer is in community. So we're honored and excited about the way that we are creating new community-centered approaches and consumer-facing approaches to data collection, but also accountability and transparency within health systems. Thank you.
Thank you so much, Kimberly. It is just always inspiring to see the ways in which the Irth app has grown and is expanding. Incredible, 35,000 users and almost at 50 states is amazing. And we appreciate learning more about the Irth app and also these concrete examples that you provided on how, again, we're using community voices, community learnings, community data to make systems change, to make impactful and meaningful change in the maternal health outcomes of Black women and birthing people. So thank you. Unfortunately, audience, we do not have time to take questions, but I will ask our presenters if you could drop your contact information, whether it's websites or social media, names, email, whatever you're comfortable with in the chat, and we'll make sure that the audience can follow up with you directly on any questions. There were also a few questions about the availability of the presentation and the slides. So the presentation will be on BMMA's YouTube live, or not live, but YouTube website. So you'll be able to access it in entirety there. And in closing, because we are at time, please join me in thanking our incredible presenters, Kimberly Seals-Allers, Dr. Sayida Peprah Wilson, and Dr. Karen Sheffield-Abdullah for their insightful presentations. And thank you, audience, for joining our webinar today. We look forward to your engagement throughout the rest of the week. Visit the official Black Maternal Health Week website to register for BMMA's events and to find local and virtual events hosted by BMMA partners. I also want to highlight our next activation, our Black Maternal Health Culture Fest, coming later this year. And please save the date for our Black Maternal Health Conference happening in Atlanta, Georgia, September 10th through the 12th, 2026. Please also be on the lookout later this year for our call for abstracts for the conference. Next slide. And a final thank you to our presenters and also to our staff at BMMA for their support in bringing this webinar together. Thank you again to our Black Maternal Health Week sponsors, including our presenting walk sponsor, Pampers, and our change maker sponsors, California Healthcare Foundation and Merck for Mothers. To stay up to date on BMMA's announcements, events, and other activities, please sign up for our newsletter and follow us across our social media accounts. Thank you.